So today, yes, we have Dr. Todd and Dr. Craig on from the University of Minnesota Veterinary Center, and we are super excited about this. We have been kind of waiting for a talk like this for, I don't know, seems like years, to be honest, just because this continues to be an issue. I know we've faced patient concerns, or we've had patient concerns dealing with animal prescriptions. So thank you so much. We'll get through these quickly. Kurt, you're muted.
All right, so we got some echo sessions coming up. I'll actually be doing next week. So we had some new people signing up for a number of interesting talks. So I think the one I'm looking really forward to, I think everybody's asked about, is buprenorphine for chronic pain. So finally got a guy from the ASAM annual refresher to come and do that talk. So lots of good talks coming up. So
yes, obviously free CME, so you will get the survey right after this. You'll get that in your email in basket. So please fill that out by Friday so Katie can get you your credits. If you could turn your video on, that would be wonderful. And as you all know by now, it's recorded. And throughout, if you want to chat in questions, we will monitor the chat. So you all don't have to try to monitor that while you're presenting. When you start, you can let us know if you want us to interrupt you with questions or just kind of wait to the end.
Remember, if you need any technical assistance, feel free to call. If you have got a patient with a problem and want to throw it by somebody, all of our emails and cell phones are right there. So sure to answer the phone when you call.
And the core site, so all the old echoes are there, information from the manual, all the paperwork, all the just the educational things. You can go check that out.
All right. And so we have talked a little bit about the controlled substance in the veterinary world, which was funny because I just had somebody from the staff say something about their dog getting buprenorphine procedure, which was kind of interesting. So yeah, if you want to go ahead and share your screen and introduce yourself a little better, that'd be great.
You got it. All right. And just to verify, everybody can see that, correct?
Yes.
Good deal. Okay, so just really quick introductions. I'll go first. My name is Chef Todd. I'm a criticalist, which in the human world would be an intensivist. The weird thing about us is ours is combined with emergency medicine. So my specialty is emergency and critical care medicine, although the majority of my time now is spent overseeing the ICU at the university, and then overseeing the emergency room doctors. And I've been at the university now for 20 years. I worked in private practice initially and did not enjoy that. And then went back and ultimately got a residency and then stayed at the university afterwards.
And hello, my name is Elisa Craig. I am a pharmacist here at the University of Minnesota Veterinary Medical Center. I graduated pharmacy school here at the University of Minnesota, and my first job was in veterinary medicine, even though I had worked in human medicine all throughout my pharmacy school years. So I've been in veterinary medicine for the last probably 17 years, but I've also worked part-time in human medicine at hospitals and clinics here around the Twin Cities, as well as compounding. I was in compounding for 2 years, in the last 2 years. And then I also worked in human pharmacy in a small independent pharmacy in the middle of nowhere in Minnesota. And so this opioid epidemic is definitely on my heart. I see it in human medicine. I've been through all of the prescription monitoring as well as within the clinic practice and making sure that our patients get what they're supposed to get at the time that they get. So this is near and dear to my heart, and I'm happy to talk to you guys today, and welcome Indy as well to your presentation.
Excellent. So we were both kind of excited about being able to present this. Lisa obviously has much more experience with the opioid epidemic on the human side than we do on the vet med side. And looking back at my experience over the years, yes, have we seen people that have come in to try and get medications from us that we knew were not for the pet, of course. And the challenge, though, of course, is to know how much of that actually occurs. As at least as I started to investigate and look into the things that we could cover for you, I was really disappointed with vet med in general and what a poor job we are doing in monitoring our controlled substances. And our plan today was kind of just take you through what medications we use that we believe are probably ones that are drugs of abuse for you, how we manage them within our hospital, how private practices manage them, what diversions we see, if any, and what evidence is out there to tell us what works and what doesn't on the vet med side. And we'll go through a couple of just quick papers. I will tell you that it was really disappointing. The papers that are out there are minuscule, and they just show what a poor job we're doing. So we'll go through that. And if anybody has questions during the time, please just stop and ask us. We weren't quite 100% sure what you wanted to know and what was going to be good for you. So just interrupt us and ask questions. Our presentation itself is probably 20 minutes or so. So we want you to be able to ask, and we'll help as much as we can. Listen, did you have anything else?
No, I think that really covers it. I think both of us come at it from a side where, as we started looking at the literature and what really was out there, we were just really surprised at the lack of evidence. And you'll see that more and more throughout our presentation. So let's talk about us a little bit. So we both practice at the University of Minnesota Veterinary Medical Center. You'll see a small picture of where we practice. Our veterinary medical center is comprised of 4 different hospitals and clinics. And so we both practice mainly at the Lewis Small Animal Hospital, which is comprised of basically all of our small animal. We also have a large animal hospital downstairs, as well as we have a specific hospital that is dedicated to equine that is off-site. It's still within our St. Paul campus, but it is not within the same building. And then we also have our West Metro Equine Practice, which is basically a veterinary clinic that is planted on the west side of the Twin Cities here, and they do only equine. And so we have 3 doctors on staff there, and then another one that hopefully will join soon that is only doing equine house or farm practice. So that is a little bit that is kind of unique to our hospital. We have one of the largest caseloads for companion animals in the country, if not the largest at this point. And we also see about 4,000 large animal cases annually. So we have a lot of patients who come through our facilities. Within our facilities, we have 16 different specialty services. And so some of those comprise of pathology, dermatology, like you would see in your clinics. We also have equine sports medicine, nutrition. And so those are some of our specific services that we have within our veterinary medical center, as well as we do a lot of veterinary research within the university.
And for the group that may not know, in vet med, small animal is considered dog, cat. Large animal is basically farm animals, so horse, cow, sheep, etc. And equine is horses. And the equine they tend to be bigger money for the race horses. And so there's usually separate hospitals and stuff for those. And our specialty services, the ones that are involved in day-to-day prescribing of medications that would be of concern for you guys as much as us, are going to be things like cardiology, neurology, internal medicine, and then emergency or the critical care services. So all of them regularly prescribe these types of medications that you care about.
So some of the drugs that we use within our hospital, and let's talk about inpatient first, because they are different than outpatient. Services within our hospital that would normally use these medications specifically are our anesthesia service. They use the most in induction as far as most, and pain control. And then our intensive care unit use a lot of these inpatient the most. So some of our drugs that we use are alfaxalone, which is veterinary specific, butorphanol, buprenorphine, like you guys were talking about. And believe it or not, when I started veterinary medicine in 2005, I had to look up buprenorphine because I really had never seen it in my human studies. And so I had to look it up and saw what it was and learned a lot about it then. And they use it a lot in veterinary medicine way before I ever saw it in my human practice. So diazepam, euthanasia solution, which will be new to you. And so if you're wondering what that comprises of, it's a pentobarbital solution. Usually 390 milligram per mil, and that's what they use for euthanasia within the hospital. Fentanyl is another big one. Hydromorphone, ketamine, methadone is a newer one on the veterinary medicine, and we use that injectively within our hospital, not the oral. We don't send that home outpatient. Midazolam, morphine, phenobarbital, and again, that pentobarbital, and remifentanil, which is another new one in our hospital. Some of the outpatient medications that are commonly prescribed at home are butorphanol, clorazepate, codeine for pain short-term, diazepam, fentanyl patches, believe it or not, gabapentin, hydrocodone and homatropine, and then the phenobarbital. We use the hydrocodone and homatropine not necessarily for pain control, but we use it for, Dr. Todd can explain that one next. Yeah, I figured you would take that one.
Yeah, primarily for any coughing problems. So all of the ones that we have, animals that have underlying pulmonary pathology and are coughing to the point that the clients can't sleep at night, oftentimes they'll come to us to ask us for medications. An example that we use those for would be collapsing trachea in dogs. The cartilage is really weak, and when they go to breathe, it'll collapse down, and so then they'll cough a lot, and so then we'll prescribe the hydrocodone for that. The only drug that we didn't list on that outpatient was buprenorphine as well, as an outpatient that we use for cats primarily.
And when we send the buprenorphine home with clients, we actually send the injectable into a little oral tube where they actually draw out their milliliter dose and they give it buccally. And it works quite well for our cats, or that cat population. And then in large animal, they use butorphanol, diazepam, again, that euthanasia solution, fentanyl, gabapentin, ketamine, midazolam, morphine, pentobarbital, and tramadol is used quite often. So within our hospital, a little bit much like human hospitals, we do have what we call an institutional license. Now, from the hospitals that I practiced here in the Twin Cities, a lot of times those institutional licenses they'll actually have their attending physicians carry those, and then the residents and the interns under them prescribe under that. We unfortunately just have one hospital license for our providers that work within our large animal hospital, our small animal hospital, and our clinic. And so literally there's one license, and then all of our veterinarians work under that. The West Metro Equine Center has their own license. So we really only have or carry 2 veterinary DEA licenses. To be able to prescribe, our veterinarians will use that number, or a DEA number, and then each doctor has a specific doctor number to be used as their identifier. So when they call in a prescription to one of the major pharmacies, they have to give that identifier to the pharmacies as well to identify them. And a lot of times they're not set up for it, or we have a lot of pharmacies who don't know where to put it, or they can't get it to go through because that DEA license has been under someone else's name. And so we do have a lot of problems with that, but that's just how the DEA has set our institution up at this point. We have talked to them and we're continuously talk to them. But when I talk to other pharmacists around the country who also practice in veterinary medicine at institutions like I do, a lot of their hospitals are set up the same way. And it's because DEA doesn't want a million different licenses coming through, especially with those residents and interns and having to change those numbers all the time. So.
Yeah, and just to add to that, so when I had first graduated and got my initial license, I got my DEA license at that time because I was in private practice. So in the clinics that I was going to, I didn't have to worry about the clinic itself having a DEA license that I could just use my own. But the longer I worked, the more I found out that most hospitals had a single one that they seemed to share amongst everyone. So I just kind of let that lapse. You'll see, though, that that's an issue because we don't have a great way of tracking who's prescribing what. Instead, you're getting a hospital prescribing very often, which means we don't know which doctors across the country are prescribing more than they should. And veterinarians are not able to obtain and I think it's called an NPI, the number that physicians or other caregivers get, but we are not able to get one of those. So we have no choice but to use the DEA the way that we do.
And part of the reason why we're not eligible for that NPI number is it's a number given by insurance companies for billing insurance. And so our pets in general don't bill for that insurance in the same way that human medicine does. And also in private practice, I do see a lot of private practices having one license for multiple veterinarians that maybe the owner carries, and then multiple veterinarians under them will carry that license. So this is a common problem within veterinary medicine. So within our state, and as you will see in the next couple of slides, every state unfortunately is different as far as monitoring opioids and their programs. And so in Minnesota, we were one of the first states to actually start the prescription monitoring program. And you guys are very aware of the PMP programs that you have to abide by within your state. It does apply to veterinarians, but only as prescribers only. And so within Minnesota, veterinarians are exempt from reporting any of that data to the system. And that's part of one of our statutes here in Minnesota. I seem to remember when it was instituted, veterinarians were seen as prescribers, and they were also supposed to be reporting that as well. But I'm assuming that statute came to light through maybe the Board of Vet Medicine, and soon after they only were only seen as prescribers only. So they were exempt from reporting any of those controlled substances as far as what they're prescribing to who shortly after. As prescribers, they are responsible, though, for performing due diligence with prescribing controlled substances to their patients. So they should be looking up their PMP for their patients. They should be obtaining an accurate medical history, and they should, within our state board, they should have that BCPR, which for veterinary medicine stands for veterinary client patient relationship. And so if another veterinarian has seen a patient, say they are on that hydrocodone, in order for another veterinarian to prescribe that, they should have a veterinary client patient relationship. And what that means within our board is that they should actually have a relationship not only with the owner, but they should have had within the last year some kind of an exam that proves that they have had that relationship. And so that is one of the things that is specific to veterinary medicine in prescribing, is making sure that they have that veterinary client patient relationship. Some of the barriers to monitoring programs in pets, and that's maybe one of the reasons why they kind of took or went back and took veterinary medicine off from doing those reporting requirements, was that sometimes our pets, we don't even have valid birth dates. So if our patients, sometimes they're gotten from the shelter and they don't know when they're born, sometimes it's really easy for an owner to go from one vet clinic to another vet clinic and change that information. And so that is definitely a barrier to seeing those. Sometimes even network infrastructure, depending on how that pharmacy puts that prescription in. I know Walgreens puts in their pet information differently than CVS. And so when I go into a prescription monitoring program and try to search for that pet, it may not always line up as far as how that pharmacy had put that information in. And so streamlining some of that network infrastructure, and even veterinarians having the capability to actually send that information to those PMP programs is a barrier.
Yeah, and just to add to that, the valid birthday thing, you guys all probably have had pets, and when you've gone to your clinic, they said, "How old?" And you said, "Oh, he's 4 years old." And magically we'll make up some date that's 4 years ago and we put it in the thing. And so it changes even amongst clinics for the exact same pet. And so it's never the same. And it's not something that is, as you can imagine, then real helpful in trying to follow cases and follow drugs. And considering that we have different owners that come in with different names, and when they come in, they may get the roommate's name or whatever it may be. So we have all sorts of different things. And then as I went through looking at the different states to try and figure out what the states were doing, some states require the animal information. Some states require the human info. So for the opioids, the human information, where we had to actually ask the owner for their driver's license, and we could put it in. But again, we were having the same problem with multiple different owners. And so when they were trying to input that information, and so all 50 of our states do something completely different. I could not find 2 states that did the exact same thing or asked for the same information. And so it causes all sorts of problems. When I looked through the data, go to the next, which amazingly enough, there were, at least as of last year, only a whopping 10 states, I'll start with that, 10 states that required veterinarians to search and report. And by that, when we say, if I write a prescription and I give it to the client to take to a pharmacy, then yes, it gets reported when the pharmacy does it. If I prescribe it at my hospital and I dispense it at my hospital, it doesn't go anywhere. And so these are the states that require us veterinarians at least, to record it. But even amongst these, so I said 10 initially, but in reality, Alaska, who was also one of the first states, actually last month has now completely exempted veterinarians. So now we're down to 9 states to do. When I looked into Alaska to try to figure out, well, why did they switch it? What changed? And essentially it was the legislature, the veterinarians and the state board essentially went and said this was too challenging for veterinarians, and therefore they didn't want to pursue it. And so they stopped, and the law went through and was passed just last month, and they no longer require it. So that one's gone off. But even amongst these states, you can see the things that get exempt is that some of the ones don't require us to tell benzos, or if it's a codeine medication for a cough. Tramadol, which is that a large problem for the human side? So tramadol was exempt as well. And so some states went out of their way to completely just get themselves exempt straight off the bat. All of these states went through and essentially said, hey, we as veterinarians don't think that we need to report these things. And so all of those states, now they're changing, but they're not all changing the same way. And they're adding some things, taking some things away. And so it seems like every year a little bit of this is different, but there's no way for us to tell, at least nationwide, what's going on. And then the last is going to be just for us here in the upper Midwest. So Minnesota, as we just said, they require that, if we prescribe it to a pharmacy, the pharmacist will then report it. But we are not required to report. We're supposed to do due diligence. I tried to ask every one of my friends that are veterinarians. None of them have ever gone into the thing to even look and see what it is. When it first came out, you had to have your own DEA license to be able to get into it. And nobody on the vet med board side or the Board of Pharmacy seems to be overly concerned about the fact that the actual dispensing part is not being reported anywhere. Iowa and North Dakota, you can look if you want to, and then South Dakota and Wisconsin, at least were vet exempt as of last year. And so they don't have to do anything.
So as far as how do we monitor specifically within our hospital and clinic, and I come in as a clinical pharmacist, we actually have what we call a dispensary within our institution. And so a dispensary is basically a pharmacy. We still have technicians, our pharmacy technicians who fill all of our prescriptions here. But basically our veterinarians it's called veterinary run. And so the prescriptions are filled and checked, and then the veterinarian who rates the prescription is essentially in charge of making sure that that prescription is adequate or it is correct. Now, I, as a clinical pharmacist coming in, I help make sure that they're following the rules and making sure that we are running the right programs and making sure that we're doing the right thing. And so some of the things that we do within our hospital and clinic is we do have Pyxis machines. You guys are very familiar with these within your practices, probably if you do hospital. When I first came, there were a lot of locked cabinets within our areas within our hospital that have it's a locked cabinet with a key and you can just open it up and you have all different kinds of good opioid drugs to use. And so we're in the process of removing those and going more into the automated Pyxis machines with especially our controlled substances. And our hospital staff has been very open and they've used those with open arms and they're very happy with that process as far as just starting to lock and control a lot of that stuff up. We do have a Script Pro robot, which we actually got from the human world, and I have a picture of it there. That is used within our dispensary. And so our dispensary technicians load it, everything is barcoded, and it basically takes one technician role as far as it replaces one of our filling technicians. And so when a prescription is put into our hospital, a prescription is put in via our hospital computers. It goes actually right through into that robot and the robot fills it and out comes a labeled prescription with all of the drugs that are correct inside. And so then it's barcoded and scanned and it lessens errors, but we do have a lot of our controlled substances within that machine. We also do make our technicians double count all of our controlled substances that do come out of that machine. And believe it or not, it is not accurate all the time. We have them double count and they will have to add 1 or 2 tablets, but it's a nice way to control that access. We also, every single drug vial that comes into our hospital, we number, which is crazy, but we number every single bottle that comes in and we have an accurate count of every single place that it's been. We also have individual drug logs for every vial. So if that vial were to go to our ICU Pyxis and let's say it's hydromorphone, it has a vial number and it has a drug sheet that's associated with that. And every single withdrawal that is taken out is hand taken down handwritten down onto that worksheet. That is something that we are looking towards moving on from as far as making sure that, we already have the Pyxis machine that is automating that. And so that is something that we are looking as far as those individual handwritten sheets of just getting rid of. But every single vial number is tracked throughout our system. We also, within the last 2 years, had a university audit, and they came through and really pointed out a lot of holes within our system. So that has greatly helped both Dr. Todd and I just really look at our processes and see where there are holes. And they've recommended a lot of recommendations that we have instilled within our policies and procedures, but it just increases the number of checks and balances within even just ordering. We have 4 different people within that process, not just one person ordering and receiving, inventorying and auditing. There are 4 separate people who do those checks and balances all the way along the way. And then we also, like I said, we have a dispensary, which is our quote unquote pharmacy. We have audits weekly within our dispensary to make sure that all of those controlled substances are tracked and audited, and we are not losing things within the hospital. Now that is a lot. We do a lot within our hospital to make sure that we monitor things. And that's not to say that we're perfect and there are holes in every place, but we've tried to do the best that we can with what we have.
Yeah, and just to add to that, so the university, our hospital is dramatically different than the vast majority of veterinary clinics, right? The vast majority of veterinary clinics are very small. They usually have a couple of doctors and a handful of staff, and they have their own medications in the hospital. I've worked at a lot of different small animal private practices over the years, and all of them have the same thing, which is a lockbox on the wall. It's required by the state board, and most of the time it's just left open during the entire workday, and then everybody goes home. So there aren't the same types of checks and balances. There are less people there, obviously, and they're seeing less pets than we are, but there is much less control everywhere else. That's more what I would consider a real veterinary hospital or a regular clinic.
And I would say that's very true. I have recently visited a veterinary clinic within the Twin Cities, and they did have what we call a Cubics machine. So Pyxis, there were some Pyxis staff that basically looked at the veterinary world and they said, "Ooh, I see that opportunity. I'm going to take everything that I have from Pyxis and make it into a Cubics machine that's veterinary specific." And so they actually had a very large Cubics machine in this clinic, which I was very surprised and excited to see. But regardless, veterinary medicine is moving that way. It's just very, very slow. And it's hard when you're a clinic owner to justify that amount of money when what you have been doing with the lockbox on the wall has worked for ages. So.
All right. So trying to find papers, I will tell you, and for those of you that maybe have looked at one point to try to get an idea of what's going on in vet med, it's awful. There is so little literature. And this is probably the best paper that's out currently. At least it's the most recent. It's a journal from Veterinary Research, which is a good paper or a good journal in our world. And they went through and tried to look at the number of or the amount of vet shopping. So vet shopping, they described as clients that were going to at least 4 veterinary hospitals, or were seeing 4 different veterinarians and getting prescriptions that were controlled substance prescriptions. So they tried to look at over this 15-year, 5-year span from 2014 to 2019, and they did a decent job of going through looking at the database to see what was in and out. And what they found essentially was that the number of these vet shoppers, these people that were getting more than one veterinarian prescribing it, so at least 4, and they found a 3-fold increase in all controlled medications over that 5 years time span. So that's a pretty dramatic increase in the number of people they believe are vet shopping attempting to get these medications. There was a 9-fold increase in opioids. And I'll show you the next slide in a second, but you can see that as the opioid number dropped off, the opioid cost numbers went up amazingly at the same time. And then there was a 2.5-fold increase in the benzos that were being prescribed to these same types of people over that 5 years span. They had reported that there was only 10 states within that they could look at that required it, which means that there are tons of limitations to this paper. And so it has to be taken for what it is. If you look at these are the actual number of patients, so actual patients that had controlled prescriptions written to them over this 5-year span. And you can see the blue bars, just kind of any controlled, and ended up at pretty much the same spot over that 5-year span. The red is the opioid analgesics that were prescribed, and they went up. And then after 2016, it slowly started to come back down. The benzos went up, peaked out at 2016, and then slowly went back down. But then the opioid cough and cold medications consistently risen year after year. Then when you look at the number of controlled prescriptions for that same patient, so the ones that are now vet shopping, trying to find medications or getting it from 4 or more veterinarians, same thing, you can see the opioids went up around 2016, they started to come back down. The cough cold stuff started to go up, and the benzos has continued to go up amongst that group of people. And then last was looking at the prevalence. So for us, for our veterinary patients, how prevalent is this vet shopping behavior? And essentially, they took the percentage of all the patients that had at least one prescription of a controlled substance made, comparing that to the number that were linked with vet shopping. And you can see that's in the gray bars that that prevalence has increased fairly dramatically over that 5-year time span. And even though the medications themselves look like they've gone down, but the prevalence within that same population of people that seem to be getting it from more veterinarians than they know had gone up. The challenge with this paper is, since the DEA was the licenses were being used by multiple people, it may actually be much higher. But at the same time, it may actually be much lower because there may be 3 doctors from the same place that are all prescribing it under that same license. And so there's not a great way to tell how to be able to know for sure what's being prescribed. And since only 10 states required at the time for them to actually report, all the rest of it is guesswork. And yeah, and so it was, while a valid attempt to try and get an idea of what's going on, it clearly has some giant holes in it.
Well, and what I would add to that is when I look at the cough and cold medications, the number one that I think of is that hydrocodone and the homatropine combination, which is a C2. And so that has a greater risk of just that drug-seeking properties, but that is the number one that I would attribute that opioid cough and cold medication to within that class.
Yeah, and it's one of the few that we prescribe long-term for a lot of patients, and so there's obviously a large impact there. Oh yeah, go ahead.
Yeah, no worries. So there was a veterinarian survey that was done in Colorado, and it was posted in the American Journal of Public Health. So the Colorado Public Health actually sent this survey out just within 180 veterinarians, and this was in 2018. So we have a little bit of time since then, but just to know kind of where veterinarians fell as far as where they thought they were within the opioid epidemic. And out of the survey that they got 189 veterinarians that came back, and they said they reported a lack of role of clarity and awareness as to barriers to overcome in the opioid epidemic. Out of that 189, 40% of them were unsure of if opioid abuse or misuse were even within their communities. They just didn't know. 73% of respondents noted that their veterinary education was fair, poor, or even absent for appropriate prescribing practices and drug opioid epidemic. 62% of those veterinarians who were surveyed believed that they had a part in the opioid abuse and misuse prevention, which is encouraging. At least over half of them say they have a part, but it's interesting to see that their education, they don't think that they got the right education, and they didn't even know whether or not the opioid abuse or misuse were in their communities. That was surprising to me. They did come out of the survey with 3 priorities as far as educational priorities. A lot of them said opioid abuse prevention. 81% said that would be something that they would be interested in. They think that the public health of Colorado, that they should actually put something out. Pain management guidelines. There are no pain management guidelines that I'm aware of in veterinary medicine. And the other one that they wanted to see is how to engage in electronic resources. Those were 3 areas that those veterinarians said they would like more information or continuing education on. So that being said, just from that survey, it shows that our veterinarians aren't well prepared for this epidemic. And there's a lot of work to be done even within the continuing education and the education even from us as a veterinary college and looking forward.
Yeah, the only other thing I wanted to add about that survey was out of that 189 that they asked, 13% said that they were aware of clients that had either injured or made up an injury or illness that required a prescription. 12% were aware of the staff that were that had opioid abuse, and then the 64% had no CE since they graduated on opioid problems and prescriptions. But the survey was also pretty lousy in that the average time in practice for these 189 veterinarians was 22 years. So there were not a lot of new grads that were that bothered me for the survey. And I realize we're running a bit long, so I apologize. I'll try not to.
All right, so let's talk about xylazine in veterinary medicine. As you know, it's a potent centralized alpha agonist approved by the FDA in 1972 for use in sedation in dogs, cats, horses, deer, and elk. In veterinary medicine, we see xylazine a lot in our large animal populations, specifically in our horses and cattle, but also out on the field we actually see a lot of DNR veterinarians using it for just using a very small amount to help calm an animal. It's very quickly absorbed. And so it allows our veterinarians to safely examine those patients closely. I just wanted to at least show you some common doses. When we looked at the literature, the average dose in humans with fatal cases that they've seen in the xylazine epidemic is about 1,200 milligrams. And then those non-fatal cases, when it's mixed with that fentanyl, they've seen about 525 milligrams in those non-fatal cases. Now, just to look at a horse and what we give in veterinary medicine, an average horse weighing 1,500 pounds or 681 kilograms. That's on the lower end of average. They normally get 681 milligrams. And so it's almost double in those fatal cases of what we're giving horses just for sedation. The FDA Center for Veterinary Medicine just came out with a document within the last month saying, here's how we're working on it. They have been working on with other offices of the FDA and the Department of Health and Human Services to stop the supply from entering the U.S. And so within the last couple of months, they've flagged 4 shipments of unapproved xylazine from 3 firms, having placed those on alert. And that is where they're centering their efforts, is on the supply that's entering. Now, there are other supplies that are going to veterinary sources and they're approving those, but they're really trying to stop it at the border. AVMA is supporting the legislation, which AVMA is the American Veterinary Medical Association. And they are supporting legislation to schedule xylazine as a C or Schedule 3 substance for humans only. So it would still remain uncontrolled in veterinary medicine. And so that's something we'll talk about in a little bit, but it would only schedule it for xylazine in humans, which it's not used in humans. And if xylazine were to become controlled in animals, our large animal veterinarians would be affected the most, and they would probably start looking for other options. But this is such a mainstay in their practice, it would definitely be still part of it. But it would just require a lot more paperwork, which is frustrating, especially to some of those veterinarians who are out on the field and trying to give a horse that needs sedation or just a little bit of calmness while they're trying to examine it.
And then I went through to try to see if I could find out the amount of abuse within the community itself. It was 11 to 13% of veterinarians developed substance abuse, according to a 2015 study from the AVMA. The primary reasons are probably the same for the physician side: high debt, moral distress, work-life imbalance. Veterinarians have a high suicide risk, therefore more mental health challenges. And unfortunately, it's about 2.1 times the national average for men and about 3.5 times the national average for women. And women are the primary veterinarians now. Our hospital, our class size now is about 75% to 80% female. So something that means we'll have more mental health issues potentially that we could help try to find some issues to help with. And then Alyssa, I'll let you.
Yeah, we'll go through this really quick. Limitations, we've already talked about some of them, but our patients really have no trackable identification like birth dates, names, owners. I did talk to some, I thought, well, maybe if we put chips in everybody, which has been happening, but the likelihood of everyone becoming compliant with this is pretty low. And then from what I understand is even the chip readers they're not universal. So we could put a chip in a patient in our clinic and go to another clinic and they may not be able to read that number. So there's just a lot of limitations to trackable identification within our patients. Veterinarians don't have the resources or the time to submit reports. Usually you're working in a veterinary clinic with limited staff and resources. And so there's not a lot of time to submit those reports and to have the infrastructure to do that. And there's no veterinary software. And then there's not a lot of support that we have seen coming from the American AVMA or governing bodies to advocate or enforce programs. A lot of times they're actually coming and siding with the veterinarians and saying, hey, this is too much work. And I mean, Dr. Todd can talk about this more.
Yeah, essentially, this was a statement that the RAVMA put out, and you can see that essentially they believe that it's too burdensome. They're finding it too burdensome for veterinarians to be able to have to track these things, and they have not gone out of their way to actually encourage or find solutions. And again, it all comes down to money, just like everywhere else. And it's a matter of trying to find money and then convincing everybody that it's worthwhile tracking.
So how do we as a veterinary hospital, as Dr. Todd came up with some solutions specifically within our practice of how we can help kind of curb this from a teaching aspect, from a learning aspect as our veterinary teaching hospital? And some of them come up with policies like what I see in the human world. Do we start to limit the amounts that our veterinarians are prescribing within our hospital? Do we start, Dr. Todd and I can start to implement opioid epidemics statistics and information in our teaching and help guide our students in the best practices to reduce unit use and diversion. We're going to look for more opportunities specifically even within our staff to reduce diversion. And I think one really big place that we can go is start talking to our boards of pharmacy and veterinary medicine. I'm kind of between the two. I have relationships with both of them. And so how do we bring those two together to help curb this epidemic within our state? And then as far as within even just our medical association, the Veterinary Medical Association, and making sure that they're more aware and putting out those resources to our veterinarians within the state. Another thing that we can do is align other DEA license holders in prevention measures, specifically look to your human world and say, what have you guys done? How can we implement that within our practices and not reinvent the wheel? And then another thing would be mandatory continuing education for our veterinarians in pain management, that abuse prevention, and electronic tracking resources. And that was the majority of stuff that we wanted to cover. We apologize for going a bit longer than we intended, but we're happy to answer any questions and such that you might have. Let me stop sharing.
I have like a million questions.
and we'll tell you, we probably don't have many answers, but we'll try.
All right, I'll start. And is there any way for with the veterinary board, like if somebody, is there any way for them to tell who high prescribers are? I mean, you talk about the fact that, so there is really, and so my second question to follow that up is there anything, for instance, if I start prescribing opioids for my family or my wife, that will clearly get me, a pharmacist is going to report me, right? how does that work in the animal world if they suddenly take care of their own animal?
So, I'll answer first, but essentially, there's not a great way that even that can get tracked enough that you would know that there's a problem, because if especially if private clinics, if they're prescribing it for pets, family pets, et cetera, that number is not being tracked by anybody or anything. So unless these people are writing it to pharmacies, it's not.
Interesting.
Yeah, and I would say the same thing. I think the board in itself could actually go to the drug, not necessarily the drug wholesalers, and start to look at who's been ordering a lot. I think that would be the first place to start looking at, and the best place to start looking at this. Other than human pharmacies, there's no other way of tracking this.
Yeah, that was my question, is that not tracked at the distributors level? Like, they know there's so many going to this building, and this is how many are going to this owner and this owner and this owner, and then there's 100 missing. Where did they go? And is there like a national agency or something that can all be reported to? And I don't know, these are probably brainstorms for the future type things. My original question was going to be about the implantable tracking things. My dog has one now, and is there a reason why they don't communicate with each other? Or is there some discussion about that? I mean, that
yes.
would be.
Well, so it
like
was
a driver's license.
It was, and it was really, really popular. Probably 15 years ago, a bunch of companies came out with them all at the same time and sold the units to a bunch of different hospitals across the country. And so everybody had them, and the readers did not work across. The new ones are, they can track the majority of them. But the issue that we end up having when we try to track them, so a lot of times I'll get a stray or something brought in, we'll scan them to see if there happens to be a chip in it. And there's a chip, but if the people never registered the chip, it doesn't go anywhere. And the vast majority are not registered that we scan.
I almost feel like I got to start asking my patients if they have any pets with severe medical problems. Really, what kind of problems do they have?
Yeah.
What's their med? I want to see their med list. And we've had a lot of tramadol issues, and honestly, I am pretty amazed by the scope of medications. I had no idea the scope of medications you were actually prescribing on the animal side. So I am a bit shocked. I think that's interesting. One of the questions I have when we look at our hospitals, we know that there's an X number of diversion, and there's ways that they look for diversion in the hospitals. Is that a frequent thing for you guys to see somebody get caught diverting, where they're putting saline in a bottle of fentanyl and then, emptying the fentanyl out? I mean, do you guys get that kind of issues?
I would love to say no, but we all know that if someone is smart enough, they're going to get it. And I hate to say that, but I mean, I have seen it, and Dr. Todd has seen it in a hospital where those things happen. Even if it's a veterinarian who's prescribing for another dog and they're picking it up for themselves, we've seen that happen. I've seen pharmacists come in and dupe us from going from, veterinarian to veterinarian, and they were caught by a pharmacy. So it happens. They're smart. And as far as staff wise, we try to do our best in training our staff well and having cameras everywhere and doing the best that we can. But unfortunately, they're going to find it wherever they can get it, and they're smart. So I used to work at a hospital, one of the hospitals here in the Twin Cities, and one of the nurses was going in, and she was taking Carpujet, and she was going in from the long end and grabbing it out. And so they're going to get it. And I hate to say it, but it's hard. It's hard to control that.
I just
I
want to
didn't
say
see if
the
there
one
were
thing
any
that
chat questions. Oh, yeah.
I was just going to mention, I think the thing that surprised me the most when I looked at this was essentially a person that wants to get the med really can just go clinic to clinic and have it prescribed, because most clinics prescribe oral stuff from their hospital itself. They just dispense it themselves. So they could very easily just go to as many clinics as they want, as long as they're not getting a written prescription. And so I don't know how much that is contributing to the epidemic. I'm sure it's just one part of the many, many things that's going on.
I do like the Colorado study, though. Not really a question with it, but I do like that there was a lot of positive acknowledgement in there that, I think the answers in that study were more reassuring than the answers in a lot of physician studies when it comes to the opioid epidemic, and taking some, at least, interest in ownership and understanding that the education needs to be there. Yeah, it's almost too bad that it can't just be universal. Like, here's the prescription and everybody has to go pick up at the same pharmacy, versus you being able to dispense. But that I can totally understand being more difficult for you all too. So.
Yeah. Aaron, did you want to unmute and ask your questions? Because it is kind of interesting. I don't know if you want to.
Sure. So you kind of asked it already. I was just wondering, there are statistics on rate of diversion for nurses or anesthesia providers and things like that. I'm just wondering, in comparison to other, human care specialties, is it comparable? Is it more of a problem, less of a problem, or maybe not as measured in your specialty?
It is not as measured. It is just there. I was dumbfounded when I tried to find actual literature that was worthwhile, and it is not measured.
So that was kind of why I was so curious about your specialty. I had looked a few years back and tried to contact, I believe, one of your professors about doing this talk a few years ago. And there was so little data out there, which was a huge draw, getting you guys to come and talk on echo, because it is something that nobody really thinks about or knows much about in the opioid space. So it's so interesting.
So here's another question. For instance, in the anesthesia world, if you get an anesthesia doctor and he ends up with a substance use disorder, maybe to fentanyl or something like that, sometimes that limits what the board will let them do when they come back. Does that exist on the veterinary side, where if you have somebody who develops an opioid use disorder, are they limited to what they can have in their clinic?
Sorry, go ahead. I'll let you go first.
I would say it's pretty unheard of, that it's not found. I've never heard of anyone within the practice that I'm aware of, or any of the pharmacists that I talk to around the country, that I've heard of an anesthesiologist or anesthesia technician having that case. Now, not to say it's not happening, but I just don't think they've been caught.
And so the few cases that I know of diversion that have occurred from a veterinarian and went to the board, obviously they attempt to get them support, but the license is revoked initially, but is given back provided they go through all the steps. And the one that I know of most recently, the veterinarian had changed states, and the info didn't transfer to the state from here to there, and so they got a license there that they did not have here, and went about the day.
Wow.
Yeah.
Who's going to reform this?
We would love to say that, but we're so limited. And I mean, we can do our scope here, but it's fighting against our veterinary boards, and the AVMA is the hardest thing. There's a lot of money behind them, and there's a lot of veterinarians who are saying, you can't do this to us. So we would love to. I mean, Dr. Todd and I just have talked long about how can we save this.
Yeah, and when I read the Alaska stuff, the veterinarians that fought so hard to get it lifted again, and going through and reading their comments on the surveys that they filled out, all of them, the primary thing was, we don't think that this is actually helpful for the human side. It is too much work for us, and it costs too much money for us to spend time doing it. And they convinced the legislature to pull it. And so I don't know how you fight that.
And I almost think DEA or a federal entity is going to have to come in and really flex their muscles and say, this is it. Like, we need to start reforming this. And they will listen once it comes from that level.
Yeah, they'll have no choice. Yes.
Hmm.
Do you have any kind of speculation on, because you have the different, the small animal, large animal, equine, where there might be more like diversion or, I would think at the, the small animal, they probably, I'm just assuming, I have no idea, have more visits, and it's easier to say like my dog got hit by a car than it is, like my cow did or something. I don't know, like an easier level to get more meds.
I asked a friend that is a large animal veterinarian, and they do not prescribe anything to go home. So from that point of view, it seems easier. It may be higher amongst them abuse-wise within the staff itself, just because it's a more demanding physical job, and so I can imagine how that might happen. But whether or not it occurs more, I don't know.
I have a family member who is a veterinarian, and we talked about this in depth, and he thought small animal just because there's a lot of routine elective procedures that are happening, so that was kind of an interesting perspective on it. But I asked the same thing, Heather. It's just, like, what's the likelihood? I suppose the dosage would be higher in a larger animal, but yeah, it's thought provoking, definitely.
But even when I looked at the medication, the dosages for a lot of these opioids that we prescribe, that are on the human side, the dosages are pretty high. Like when we look at like prescribing something for like a shepherd, we're prescribing it for a 30-kilo animal, and the dosage ends up being pretty high and could definitely be an abuse potential. And if you send home multiple days of that, so from a small animal hospital, it's probably much more likely to occur.
That's interesting that their doses would be, it sounds proportionately higher than it would be in a human.
I always get questions when I call a pharmacy. Yeah, when I call a pharmacist to order something, they're like, really? Did you want that much? Yes, and the dose. And it always seems surprising to them.
Wow. Well, we're about out of time, I guess. So I don't think we can thank you enough. This was eye-opening. Yeah.
I'm glad we could hopefully answer some stuff.
Yeah.
Well, in our,
we've been waiting for this for years, so thank you.
Well, and we're also know that we would love any information from you guys. If you guys have suggestions for us, just things that you're seeing that we can bring into our practice, we would love any feedback. That would be great.
Interesting. So, well, we thank you very much. It was very interesting, and we may have to have you back again at some point down the road and see if things change, because it is kind of interesting at the moment. So
maybe that needs to be a question when you start a new patient, like part of their care plan to start them on opioids is, do you have any pets, and just document that. So put them in a higher risk category.
You ever had a pet who's had an opioid use?
Thank you so much.
So, all right. Well, thank you again, and we really appreciate your time. And thanks everybody for coming, and we'll see everybody next week.